My name's Alison, and I'm a health psychologist and a researcher working in a Lewy body dementia clinic in Newcastle. And it's my absolute pleasure today to welcome you to this very exciting launch of the community of practice for Lewy body dementia. And I'm welcoming you on behalf of the 7 of us who've brought this into existence, and all of whom you will hear from later on today. So I'll just run through our plan for the hour or the hour and a half. And thank you for those of you who've given up your lunch hour or lunch hour and a half, which I'm sure none of you get, to attend today. So I'm going to just give you a little introduction to the community of practice. And then, as you see here, these are my colleagues who are going to each have a little slot. We thought it would be really helpful to give you an overview of how many people and how many health professionals are involved in the journey of people with Lewy body dementia. And then towards the end, there is an opportunity for you to have your questions and answers, or your questions answered. So you have got the facility to pop things in for the Q&A. Please do that as we go along, and then we'll answer them at the end. And there should be an option for you to promote the questions that you're particularly interested in, so that we get to the popular ones, or the most popular ones. Please don't worry if we don't get to all of them. There will be more events coming up, and it'll be really helpful for us to see where there might be particular gaps in knowledge that we can focus on in different sessions in the future. So thank you for getting involved in that. Okay, next slide, thank you. So yes, as I said, my name's Alison. My particular interests in terms of Lewy body dementia are on the research side, and particularly psychosocial research, although I am currently also involved in a clinical trial, and particularly at the moment looking at interventions for carer support, and also trying to raise awareness particularly in groups from lower economic social groups, and people who are often underrepresented in research and who are less likely perhaps to seek a diagnosis or to seek ongoing care and support when they've got a diagnosis. So that's really the focus of my work. So what actually is a community of practice? Well, some of you will probably already know, because a variety of other health conditions do have a community of practice associated with them. This was quite a new thing for me, and maybe for some of you. And so just as a small bit of background, the phrase we think came from this gentleman, Etienne Wenger. And you can see how he described this concept here. So we want to be a community, so a group of people that interact regularly. How regularly remains to be seen, but we hope to put on events certainly several times a year. We're all practicing, aren't we? None of us are perfect. None of us have all of the answers. So we do want to all learn how to do things better, how to improve our skills, our knowledge, and our practice. And we share a common concern, in this case, for Lewy body dementia. So why? Why do we need a community of practice for this condition? These are the reasons we came up with. You may have some to add to it. So just briefly, professional growth, it's a professional responsibility, as well as us wanting to improve our practice for personal reasons, and both as individuals and as groups of people, both in a diverse range of health professions or within one group like nursing or physio or whatever it is. So for professional growth, for some people, perhaps people on this webinar, you might be the only person in your area of work who has any interest or knowledge about Lewy body dementia, that might be quite discouraging. So we hope this will be a source of encouragement and motivation, and that you will be able to share what you'll learn with your colleagues. As we go on, we'll have some opportunities for problem solving, for breakout rooms in future sessions, for case discussions and things like that, that people can bring their specific issues and we can look at them from the perspective of the range of health professionals that we'll have involved. Time goes on, we're going to be building a database of different resources which you can download. There'll be recordings of this webinar and future webinars, and things that you can print out to share with your colleagues or to share with carers or patients, and opportunities for you to have further training, and there will be opportunities for you to choose or help choose what the future sessions look like and what you think will be helpful to you. So hopefully that will be good as well. And the way that we see the COP operating at the moment is under the umbrella of the Lewy Body Society. Probably most of you are familiar with this charity, which is the only charity specifically dedicated to supporting people affected by Lewy body dementia within the UK. And the Lewy Body Society are currently upgrading their website, and it will have in the future a password protected area that you can join, and that will be where you will find out information and gather resources and things to do with this community of practice. So that's in the future. Hopefully the website will be ready in the next few weeks, and we will inform you later about how that's going to work and what you need to do next. So as we go through this webinar today, you'll get introduced to each of the members of the core team, and I'm just going to pass you over now to Rachel.
Thank you, Alison. That's great. So welcome everybody. Delighted to be here. My name is Rachel Thompson. I work as a consultant Admiral nurse for Lewy body dementia. You're going to be hearing about Admiral nursing from my colleague Rachel Webb fairly shortly. But I've worked in dementia care for a number of years, probably about 25 plus, and have specialised in Lewy body dementia over the last 3 years. So I'm going to go on to the next slide, if that's okay, Angela. So really what I'm going to do today is just give you a very whistle-stop tour, an overview of Lewy body dementia. And the other people in the core group will be talking about their roles in supporting people, particularly around some of the kind of complex and troublesome symptoms that people experience. So this is an overview. So just to start off with dementia, we talk about it as being everyone's business. And I don't know many people who don't come across in some shape or form, somebody with some kind of diagnosis of dementia. But overall, the numbers are growing. More recent figures seem to suggest that actually the number of people with younger onset is more than we thought, so about 71,000. And people may be familiar that actually in Lewy body dementia, we do see some people with a younger onset. It's still more common in older people, but certainly with dementia with Lewy bodies, it's sometimes a little bit more prevalent in men and can occur in people under 65. So it's worth just bearing that in mind. And the majority of people are still cared for by families in the community, although a significant number of people are in care homes, and still the statistic around 1 in 4 beds in a hospital is occupied by somebody with dementia. So next slide. So just again, some of you may be very familiar with dementias, but just as an overview, and really just what I wanted to highlight is the incidence of Lewy body dementia. It is much more than we previously thought. And certainly what we say now from the best studies we have, it's about 10 to 15% of dementias. But more recent studies, autopsy studies, seem to be suggesting that it can occur in about 25% of people. And this is often when people have both Lewy bodies and Alzheimer's pathology in their brains. And as is evident on this slide, there are a number of different types of dementia, which we're not going to talk about today. So next slide. So Lewy body dementia is the most common disease you've never heard of. It was a phrase coined by the Lewy body Society. We think about 100,000 people with Lewy body in the UK, and we classify Lewy body dementia as an umbrella term for both dementia with Lewy bodies and Parkinson's dementia. I'm going to talk about terminology in a minute because I think different diagnoses, different terminologies are sometimes used. But just it's important to highlight really that not everybody with Parkinson's disease will go on to develop Parkinson's dementia. About 30% overall, but the longer that people live with Parkinson's, the increased risks they have of developing it. Next slide. So that pink picture there is a stain of a Lewy body. You can also get Lewy neurites, which are smaller areas, but the Lewy bodies are essentially, it's an abnormal protein, a misfolding of a protein, which is mostly made up of something called alpha-synuclein. It was discovered by Frederick Lewy, hence named after him, in a Parkinson's patient. And essentially what happens is the protein misfolds, it forms into clumps inside the neurons, and this can lead to either a change in the function or the death of the neuron, but significantly loss of production of very important neurotransmitters. Firstly, acetylcholine, which people will be familiar with in terms of Alzheimer's disease, but also dopamine, and this is where the crossover and the relationship with Parkinson's comes in. So this slide just shows you kind of through an image that essentially these two conditions have a lot in common. So Lewy body disease can lead to Parkinson's disease, and some of these people go on to develop dementia, but can also lead to dementia with Lewy bodies when the Lewy bodies in certain areas of the brain. Next slide. So the 1 year rule, this was a consensus report that was developed by Ian McKeith and colleagues up in Newcastle. And really it's just helping us to kind of differentiate between the two. So Lewy body is the umbrella term. Parkinson's dementia is where dementia starts 1 year or more after a fairly well-established Parkinson's disease. So this is where it's really important to ask people questions about which symptoms occurred first. Dementia with Lewy bodies, DLB, is where the dementia occurs before or sometimes at the same time as Parkinsonism, or within 1 year of the onset of motor symptoms. Just worth noting that in dementia with Lewy bodies, that some people don't actually present with motor symptoms until very, very late on in the condition, or even at all. So where are the Lewy bodies found? Well, in Parkinson's disease, they're usually found in the midbrain and the brain stem, and you'll see in the black writing, these areas of the brain are very important in controlling our movement, but also the brain stem is significant in regulating sleep, maintaining alertness, and also controls a lot of the autonomic nervous system symptoms. So things like bladder, bowel, blood pressure, temperature, swallowing. So hopefully you'll start to see why some people present with certain symptoms. If somebody has Lewy body dementia, so this is either DLB or Parkinson's dementia, then what we see is Lewy bodies occurring in the cerebral cortex and more diffusely. And you'll see here cerebral cortex is where important information processing, perception, thought, language, forming new memories, and lots of other functions. Next slide. Thanks, Angela. So what are the symptoms that we see in the people that who have this diagnosis? So it's a multiple complex condition, and the core features are highlighted in pink. Now, these are the core features again that have been classified, but some people may present with one or two of these and not necessarily all of them. But things to look out for, and this is where dementia with Lewy bodies or Lewy body dementia differs to other types of dementia. Memory loss isn't often the first feature that happens. What we often see is fluctuations in cognition. So this can be from moment to moment, hour to hour, and this is in attention, concentration, ability, executive function, those kind of functions. Visual often So these are often three-dimensional, maybe of people, of animals, sometimes distressing, and sometimes often people say they can be quite comforting, interestingly. Sleep disturbance can occur in we think about 90% actually of people with Lewy body dementia, and maybe one of the prodromal features. It's seen often much earlier than other symptoms, but particularly REM, sleep behaviour disorder. And this is the core feature where this is a dream enactment, where people move around in their sleep. And then Parkinsonism is the other core feature, and certainly in dementia with Lewy bodies, you may see more balance or rigidity, and sometimes tremor on movement. And then you'll see there's lots of other symptoms that present, orthostatic or postural hypertension, delusions I've put, including Capgras. People may be familiar. This is where somebody thinks somebody's been replaced by somebody. It's called delusion of misidentification. And also anxiety, depression, apathy seem to be particularly prevalent, and we think a lot of people retain insight. Now, compared to other dementias, Lewy body dementia, people do seem to progress quicker, and particularly when people have a mixed pathology, so those with Alzheimer's, which may be found on autopsy, wouldn't necessarily see before that. So again, Alison said, why is this an issue? People we still know are underdiagnosed. So for people with dementia with Lewy bodies, people are often misdiagnosed with Alzheimer's disease. The Diamond-Lewy study showed about 46% of people had another dementia diagnosis prior to getting their Lewy body dementia diagnosis. People have multiple visits. There may be lack of assessment of key features. So this is I often say to people in memory services, look out for things like hallucinations, ask questions about sleep, and maybe just notice movement disorder. In Parkinson's dementia, sometimes the symptoms can be attributed to medication, side effects of medication, particularly the levodopa medications. Maybe the cognition's not assessed, or occasionally maybe the value of diagnosis is not recognised. Next slide. So we're not going to go through this in detail, but if you haven't heard of the Diamond-Lewy, please do go have a look. A couple of the people who are presenting today, Alison Bentley and Alison Killen, were very involved in this work. But just put Diamond-Lewy into any search engine. It's got some assessment toolkits in there to help with diagnosis. And it's also got a management toolkit, which is backed up by some of the evidence, the best evidence we have around management and treatment. And this is particularly helpful because Lewy body dementia has a kind of complex interplay between different medications, and it's really important we get it right. So next slide. And I just really wanted to kind of finish off by touching on the challenges for families, which is why we think that Lewy body dementia is so important that we are aware of the impact. So as I've alluded to, often the diagnosis is late or more complex. There's a particularly significant impact on families and people with the condition. Studies have shown poor quality of life and well-being as compared to other dementias, and probably because of the numerous and complex symptoms. Family carers often have higher stress levels, and people do go into hospital more often, have poorer outcomes and poorer prognosis. Also, there are a number of studies that have led by some of the people who are presenting today, that there's a lack of appropriate information and post-diagnostic support, and particularly around some of the atypical symptoms, and families do talk about poor coordination of care. So I think from a final slide, just to make people aware, there's a growing number of leaflets and information available on the Lewy body website. These information leaflets here can be downloaded, and for families these can be sent free, but if you just look at the lewybody.org website, you'll be able to find out more. So that's it from me, and I'm going to hand over to Rachel Webb. Thank you.
Hello, so I'm Rachel Webb. I'm a Lewy body Admiral nurse, and I work with the Rachel who's just done her presentation. So we work between Dementia UK and the Lewy Body Society, and we support people that way. My area of special interest, obviously, Lewy body dementia, and also the wider impact of dementia on families. So obviously I've just said that we work for Dementia UK, so we're Admiral nurses. Next slide, please. So Dementia UK is a charity that was set up by this chap's family. So this is a chap that's known as Joseph Levy, and he was known as Admiral Joe. And his family found that when he was diagnosed with dementia, there was no support for them. A lot for him, but not for him, not for them. So they set up the charity Dementia UK. Next slide, please. So what is an Admiral nurse? Obviously, we're named after Admiral Joe. It was interesting to see, so we don't actually have anything to do with the sea in that sense. So we're specialist nurses, and I think at the last count there was about 430 something of us across the UK. And we work in a various of different settings, but our role is to support family carers and people living with dementia. And as they say, we work across a various settings, from hospices to acute hospitals to community settings, or like our service, which is a virtual online service. Next slide. So our service was started in 2019, and it was looking at focusing just on supporting those with Lewy body dementia, because we were finding that when people contacted Dementia UK, there was dementia services out there, but a lot of them, even though they're specialised in dementia, still weren't quite understanding Lewy body dementia, and it was becoming more prevalent, so more people were being diagnosed. So the type of support we offer, because we're covered nationwide, so we take anywhere in the UK, we offer telephone and virtual support. And we offer in areas where there's no Admiral nurse. If there's an Admiral nurse in that area, we can support the Admiral nurse to support those people. And all our referrals come via the Admiral Nurse Dementia Helpline or virtual clinics, which is online clinic, a bit like the helpline, but people can pre-book an appointment to be seen at a set time. So what type of referrals we take? We don't take everybody with Lewy body dementia, because obviously there's only Rachel and I, and we've become overwhelmed. So we take those people that are difficulty managing the distressing symptoms that Rachel's covered in her presentation previously. We also support people trying to access a diagnosis. So if someone's really struggling to get a diagnosis and being passed around numbers of different professionals or health services, then we can kind of help with those things. We also look at distressing and caring relationships, how relationships and roles have changed when people need to adjust to that initial diagnosis. We also manage with the comorbidities, because obviously, as Rachel explained, people can have Parkinson's symptoms as well as dementia, and we often find they get passed between various different services without really getting an answer. And we also look at the medication to do with managing it with the association with their comorbidities, because one service might prescribe something that another service tells them to stop. So how do we do this? So I'm not going to throw a slide, because quite a bit on here. So basically we do it in a few different ways. So when somebody comes to us, we give them a triage assessment and decide which approach is appropriate for them. So sometimes we do psychoeducational, emotional support with that person or that family. So couples work, sometimes we work with a number of siblings, and being online is actually quite helpful, because we do have siblings that log into a meeting from either end of the country, so that makes life a bit easier. We also run something called the STAR program, which is an 8-week 8 session, and that follows it's a manualized intervention. So we send people out a booklet and we work through that over that period of time. We can work with couples or families. As I've said, sometimes we get a whole family on a call and we kind of identify possible conflicts and how best to support people. We've worked with siblings that aren't quite getting on when it's a parent. So yeah, we could do all that type of stuff. And then the other thing we offer is a psychoeducational group, similar to the START program, but a group setting. So START we do on a one-to-one basis or with just one family. The group is that we have a number of people that can join the group on Zoom, and we do 6 sessions, and it helps carers develop. So the carers run for people, the group is run just for carers, and we help people develop coping strategies for any behavioural concerns that they may have or symptoms they're not understanding. And we also look at self-care for those carers as well, about how to look after themselves. So these are the contact details for us. So if you want more information about Dementia UK on the website, obviously I mentioned that our referrals come through the helpline. So if you have contact with carers that you may think may need our support, please feel free to give them the number, the website link. And as I say, some people you can book an appointment with a nurse. Sometimes the helpline's a bit busy and people don't always get through. And then, as Rachel mentioned, there's a lot of information on the Lewy Body Society website. Okay, so that's me, and I'm going to hand over to Alison.
Thank you, Rachel. Yes, so my name's Alison Bentley and I'm a nurse researcher. My clinical background includes many years as a district nurse, and more recently I have spent some time as a dementia Admiral nurse in a hospice and a Parkinson's nurse. And over the past 9 years, I've been developing a special interest in Lewy body dementia, especially the end stages, which is where I did my PhD, the end stages of Lewy body dementia and palliative care. So I'm briefly going to highlight a few areas where Parkinson's nurses are likely to be supporting people with Lewy body dementia. And I've separated out DLB and Parkinson's dementia for the most part because the approaches may differ. So it's well known that Lewy body dementia as a condition is often underdiagnosed, and diagnosis can be difficult and protracted. Within Parkinson's nurse services, those that run initial assessments clinic may be ideally placed to notice if a newly diagnosed patient with Parkinson's may actually be a possible dementia of Lewy bodies. And it may be that's because the first time patients and carers have actually mentioned about the cognitive changes that have been developing for some time, or the response to levodopa has made the cognition worse or not had really any effect at all. But for the people that have Parkinson's disease for many years, the annual nurse review will identify if the patient or carer are concerned about increased hallucinations and memory and cognitive problems. And this may indicate they may be developing a Parkinson's disease dementia diagnosis. In both incidents, at this point, it may be appropriate to ask a bit more details about the memory problems they've been having. And it might be a good idea to check with the GP and the patient if they've had any recent blood tests to exclude reversible causes for their memory problems. And the key is really good clinical letter and documentation so that onward assessments by neurologists or geriatricians may be able to then help focus their mind onto a potential diagnosis. So one of the main roles, obviously, of the Parkinson's nurse is management of motor symptoms and Parkinson's medication, as we know. But depending on how local Parkinson's services are commissioned, not all teams will be monitoring people with DLB. However, it's important to note that patients with a DLB diagnosis, the starting doses of levodopa are usually a lot lower than those with idiopathic Parkinson's disease. And people with DLB have potential for more side effects such as psychosis, postural hypertension, and sedation. So the Parkinsonism symptoms are often less treatment responsive in DLB. So it may actually be that if you're entering into the Parkinson's system because they're on a Parkinson's medication, you may actually be withdrawing that over time if there's no obvious improvements or they've had increased problems with it. And not all people diagnosed with DLB will be on Parkinson's medication. And people that have had Parkinson's disease for a long time, there may be a gradual withdrawal of their PD medication to try and reduce the hallucinations and see if that then improves their memory disturbances. But at this time, it's always a careful balance between making the motor symptoms worse or the cognitive system worse. And you often have to work with the patients and carers to see what their priorities are at this time. Okay, next slide. So another role for the Parkinson's nurses can be signposting newly diagnosed Lewy body dementia. For those with DLB, this really depends on where they were diagnosed. If they've come through the neurology system, they may not have been offered any dementia support in the area. So it's useful for the PD teams to know what's available locally. This is particularly important if they will be discharging the person with dementia of Lewy bodies from the Parkinson's team, as many people with DLB fall through the net and gaps in services. It's also important to ensure they have details of societies and groups who have a greater understanding of the complexity of their condition, such as the Lewy Body Society, as we've heard today, Dementia UK, and the Rare Dementia Support Group. And around this time, it's also useful to consider advanced care planning, such as power of attorney, and if they've heard any previous wishes about their healthcare, they think it's important for the team to be aware. Next slide. So given that the large number of people on the Parkinson's caseload may have mild cognitive changes, Parkinson's disease dementia and undiagnosed DLB, it's useful to develop someone with the team with additional knowledge of Lewy body dementia. This can be achieved by close working with local services, such as mental health practitioners, and additional training, such as that offered by the Neurology Academy, both line on and in person. And the Lewy body dementia course, I think, has only been running for a couple of years, but it's been very successful. So the Parkinson's nurse plays an important role within the multidisciplinary team, as we know. For those with DLB, it's very useful to assess and refer early on for therapy and particularly continence services, as the autonomic nervous system can already be quite impaired by the time of diagnosis. And much of the background research that I did, the problems of continence really affected the person's ability to go out and maintain their social activities. This is also a time when needs for services dramatically increase, whereas those who've had Parkinson's disease for a while may have already been in contact and have embedded management strategies. However, for both PDD and DLB, medicine management is often crucial at this time. This is ensure that they're actually taking the correct medications on time regularly before any major adjustments can be made. And finally, with the recent development of integrated care services, it's an important time to consider if and how local services are being redesigned to be more integrated, and if so, how this can be improved to meet the needs of this complex group. Thank you very much.
Hi, thank you. My name's Claire. I'm the Specialist Occupational Therapist in the Derby Parkinson's team. So yeah, I've kind of developed a interest in Parkinson's disease dementia and dementia Lewy bodies over the last 20 years. So it's interesting to understand the role of the general OT core assessment processes, and also the more specialist intervention that we can provide. So obviously as an OT, we would do a complex assessment of the patient's abilities, including their activities of daily living. This may include issues they have with feeding and getting around at home if they have more issues with mobility. It's just important to understand that equipment may not always be the answer. In Parkinson's disease, generally, patients struggle to learn new things, so and particularly with the kind of dementia symptoms. So using a new piece of equipment might not be the way forward. It usually is managed by strategies. Just concentrating on Lewy body dementias, the role of the OT would involve definitely advice and education regarding the condition. The more the patients and carers, families are aware of the symptoms and providing that psychological support for them is a key aspect of it. Support for carers and spouses would also include the referrals and signpostings, as Alison has just mentioned. But as an OT, we would probably concentrate on the following symptoms of Lewy body. So that's the dissociative, poor attention, concentration mainly, anxiety and agitation, which can be more prevalent in Lewy body dementia rather than the Parkinson's disease dementia, but evident in both. But you tend to find that those with the earlier cognitive issues become more anxious and agitated. Hallucinations, obviously, and then fatigue can be a huge impact on any kind of function in and around the patient's home. So it's really important to educate and advise on that. And REM sleep behavioural disorder. On the next slide, thank you. I'll just detail that in a bit more. So for the cognitive decline, dysexecutive syndrome, poor attention concentration, a full complex assessment of the cognition is really important. Using different assessments. The ACE-3 is probably a really good detailed assessment to go with. Some treatment interventions might include cognitive stimulation. This can be done as part of a group, or even support of cognitive stimulation at home with carers, and there's lots of evidence around how this is useful to advise and help with carers at home to help with this cognitive stimulation. And obviously advise on prompts and adaptations around at home that will help with the dysexecutive syndrome, maintaining attention. Anxiety and agitation can be triggered by a number of things, mostly fatigue and stress, if not medication. So it's really important to talk to the patients and carers about routine management, how they manage their activities on a day-to-day basis, and how they manage their fatigue, including daytime rest, those sort of things. And also relaxation is useful for anxiety, along with a number of different things like mindfulness, that sort of thing, depending on the level of cognition. There's a number of different ways we can talk about managing hallucinations and the delusions. Distraction is a big one, but a lot of the time it's around supporting the carers who live with the patients to make decisions on how best to manage those hallucinations there and then in that situation, and how they are supported with that. And finally, REM sleep behavioural disorder and fatigue. Again, it's about routine management. It's about managing, reducing stress, and ensuring that they have enough information about the fatigue and how they manage that. Just thinking about the cognitive strategies, and particularly when we're talking about maybe things like activities of daily living or transfers at home, simple things, getting in and out of bed, getting in and out of a chair. It's really important to educate the carer on the cognitive strategies for managing movement, about reducing the multitasking. Patients may struggle to get in and out of a chair, and the more they try and do that, the less likely they are going to manage it if they're getting more anxious, more agitated, and the situation becomes more stressful. It's about breaking that activity down into different components, and making sure that they have full attention and concentration and focused on that one activity. The stop, think, plan, do is really about stopping the patient trying to do something they can't do. It allows them to then focus and think about what they actually are trying to do. It's really important to get them to plan how they're going to do this before they do that. And these are just really good strategies to use with any different activity that a patient is trying to do at home, and teaching the carers how to manage this. So that's the intervention of OT. I'll pass you on to Fiona.
Thank you very much, Claire. My name is Fiona Lindop. I'm a specialist physiotherapist, also in Derby, working with Claire. We work in a multidisciplinary team that specialises in Parkinson's and related disorders. So we see quite a lot of Lewy body dementia alongside all the other Parkinsonisms. My particular interests are in therapy management and using music to try and cue people to help with their gait and strategies and things like that. So the role of the physio in Lewy body dementia is very similar to what it is in Parkinson's. And it's looking at somebody's physical activity levels, because that really is primary. How active someone is probably going to determine quite a lot about the way that they will progress. We will also look at gait, and obviously balance and falls alongside that. A lot of falls happen when somebody is walking or transferring. So we will look at transfers as well, including getting out of a chair, getting out of a bed, but also can they get off the floor? And it's also important to address posture. It's often not included as a separate item in a lot of the guidelines for Parkinson's, because it's assumed to be incorporated in everything else. But I think posture is one of those things that sneaks away with people becoming a very flex posture. Very quickly, very small changes happen. And if we can be on them at the beginning, we might be able to prevent future problems. The next slide, please, will tell you a bit more about the intervention that we do under those headings. So in terms of physical activity, it is important to use the word activity perhaps more than exercise, because a lot of people are not gym bunnies and they maybe haven't exercised for decades, and the whole idea of exercise just puts them off. Other people might love it. So it's important to try and find out, but then to find ways to help somebody be more active. Can they improve or increase their strength, their flexibility, joint range? Can they get themselves a bit out of breath, hot and sweaty, because that's where the biggest advantages are going to be. And although there isn't that very much evidence in Lewy body for exercise, what exercise does to people with Lewy body, there is in Parkinson's. And we know that it can make new blood vessels in the brain. better connections in the brain, and have an overall improvement in things like cognition and sleep and apathy. So it's going to address those things. You obviously have to adapt it for the cognitive problems in Lewy body, but finding ways to keep people active is really important. We will also look at gait, and particularly for the people that are experiencing freezing, we use cues and strategies. Claire's already alluded to some of the kind of cognitive strategies that we might use, but also in terms of transfers, breaking things down. But we use internal and external cues in Parkinson's. So an internal cue is something generated from within the individual. That might be less likely to be effective in Lewy body. So you might be more likely to be using external cues, which use a different pathway in the brain. So you might use visual cues such as Post-it notes on an opposite wall to try and help somebody get through a doorway without freezing, or a laser pen to point a line on the floor to help people follow it to walk, either with bigger steps or to approach a chair to get to sit down in it rather than stop about 3 feet away. And you can use auditory cues as well, such as just somebody saying big steps in a bossy voice. But you can also use metronomes and music. And I use music quite a lot in terms of just helping people to improve their gait. It's also important to look at whether or not they need a walking aid. And as Claire's already said, it might be more difficult for them to learn to use something they haven't used before, or something a bit more complicated. Next slide, please. Looking at balance and falls prevention is really important, and that might again involve an exercise program to improve their balance. But we'd also be looking at the environment that they're living in, not just the house, but what's happening outside. Maybe they spend a lot of time in a shed or the garage, and looking at where they might be falling, which direction did they fall in. People are more likely to fall if they're reaching up above their head, reaching down below their knees, or turning. Freezing of gait we've already covered, but that does need to be addressed with an external cue. Posture, the first thing is to point out that somebody has got a change in their posture, and I usually do that by doing the tragus to wall measurement, which you stand them against a door or the wall and measure from the wall to the soft triangle part at the front of the ear, with their head in neutral. And very few people can still get their head on the back of the door. Most of you, if you go and try it after this, will be able to. But often people have already started coming forwards. But with the right exercise, particularly for upper thoracic region, you can improve that. And just being able to improve it can actually help people feel better about it, and ultimately improve all sorts of things further down the line. Transfers become difficult simply because they're not automatic anymore, and external cues can help. And using cue cards where just the key word for the strategy is written. It's often better if it's written in different colours and written in a sort of diagonal so that each step is something separate. For turning on the bed, you can advise things like a satin strip in the middle of the bed, just a single thickness, that they can then slide on that, as long as they don't wear satin pajamas, otherwise they'll slide straight out onto the floor. And educating the carer or the family member, particularly with strategies, so that they can give the key words that might be required to help them to cue somebody into bed. And we had that with one patient who had Lewy body, and it was taking 10 minutes every night to get him into bed. But once his wife knew the key words, it took 2 minutes. Next slide, please. I think that might be me. Yes, I'm handing over to Angela.
Thank you, Fiona. Hello, my name's Angela Penny. I'm a speech and language therapist working for Airedale here in Yorkshire. I work with people with progressive neurological conditions such as motor neuron disease, Parkinson's and Lewy body dementia. So the role of the SLT working with Lewy body dementia includes providing education about communication and swallowing difficulties for other professionals and for families and carers. We provide support for carers and families, including us referring on to other services where needed, for example, dietetics advice or signposting to carer support services. And SLTs assess and manage eating and drinking difficulties, saliva and communication. And this can include assessing speech intelligibility, which could be effective from the motor movement control involvement. But also in Lewy body dementia, this language and cognition can be affected, which impacts on how somebody communicates and how well they function in conversation, in making their needs known, and how they can participate and interact in family life. So symptoms that I'll cover. So dysphagia or swallowing difficulties, this can affect how well someone is able to chew and swallow food, swallow fluids, or manage their own secretions. And difficulties in this area can lead to weight loss, respiratory infections, reduced enjoyment of meals, or reduced participation in social occasions involving eating and drinking. Some people have too little saliva, and this can affect how well dentures fit, how comfortable their mouth feels, and their speech and their swallow. Different speech systems can be affected in dysarthria, for example, volume, voice, articulation, intonation, and these can all impact on intelligibility of speech. And language and cognition might impact communication as well. There can be difficulties with finding the names of common objects, a reduction in verbal fluency, problems following conversation or in initiating topics or keeping up with the tempo of conversations. And SLTs therefore provide a holistic picture of communication difficulties and patient needs from both language and cognitive assessment and functional information, for example, from observations of communication in action between family members, or the family members' reports and insights of how communication has altered. We need to remember at the point when we come in that changes will have been gradual, and the person with Lewy body dementia and their families and carers will have been spontaneously developing strategies to cope with the changes, some helpful, some perhaps not so helpful. So part of our role can be in teasing this out. And we must take account of the variability that people with Lewy body dementia have. It also shows up in communication and drooling and swallowing difficulties. So we might see them at their best in clinic or on our home visit, but they could have times when they're a lot worse, and it can be a big difference. There's so many things that can derail people: infection, hospital admission, moving to a care home, changes to medication. So we need to be aware of what's going on and provide strategies to manage the worst times as well as the better times. So in dysphagia management, SLTs will be able to advise on safer swallowing strategies, such as optimizing posture, positioning, alertness when swallowing, or adjusting bolus size or pace of eating and drinking, and reducing distractions. We assess and advise on reducing risk factors for developing aspiration pneumonia where possible. Dysphagia itself is only one factor to consider. Others include dependence for oral feeding, dependence for oral care, poor oral or dental hygiene, chest concerns, comorbidities, taking multiple medications, and poor mobility status. So we can look at those overall risk factors and see what changes could be made to reduce risk factors, even with the dysphagia itself remaining the same or worsening. For example, we know a major risk for developing aspiration pneumonia is harmful bacteria from the oral cavity entering the lungs. So our advice may be to include increasing oral hygiene events. And we know that being fed or helped to drink is very different to doing it yourself. So we might provide advice on feeding techniques. We also assess, advise, and sometimes provide, dependent on local service funding, specialist feeding equipment that can help swallow control, for example, one-way valve straws or cups that provide a certain bolus size to swallow or which are easier to hold independently. And SLTs will assess and advise on texture modification of food or drink where appropriate. And we can work with other members of the MDT, for example, the GP or the specialist nurses for medications to reduce production of saliva, being careful not to go the other way into dry mouth, of course. And in communication management, we may work on strategies to increase volume if this will help speech intelligibility. This may be less impairment-based therapy compared to our work in Parkinson's disease. For example, our aim might be for those external cues, prompted volume increase when needed, rather than the attention to effort therapies aiming for independence in producing that effort needed for increased volume that people with Parkinson's might work on. We can embed our volume practice into language work. A person may be practicing a script where they say certain information about family or an interest they have, and we can use this to practice volume as well. Working with the person's conversational partners is essential. We can advise on specific strategies to help them communicate with their family member or the person they care for, how to improve comprehension, how to help with volume or word finding difficulties, ways to help them start or continue in conversations. And SLTs assess and provide AAC, so alternative and augmentative communication methods where appropriate. This could be low tech, pictures, paper, written words, or it could be using higher tech methods depending on someone's baseline tech skills. We wouldn't be teaching new tech skills, but we could utilise what they can already do, using apps or taking photos on their smartphone, for instance. And finally, SLT management might include life story work. So that's utilising photos and life memories in whatever format works best for the individual. It's about their family, their work, themselves, to affirm their life and identity, promoting dignity and respect in documenting and sharing their life story. If the person with Lewy body dementia wishes to do this, then the earlier the better, so they can participate more fully. So that's me. Please pop any questions in the Q&A, and we should have time for all questions from all the sections at the end. I'll now hand over to Alison, who'll be discussing the role of the researcher.
Thanks, Angela. So yes, back again, and this is the last of the sessions from the 7 of us explaining our roles. And we've included the role of a researcher because often as health professionals, you're either aware of research or signposting towards research, but there are obviously a number of people who are dedicated research nurses working in the dementia and the Lewy body sphere. So I hope that will be interesting. Next slide, please. So if a patient or a family member is thinking about taking part in research, one of the things they unsurprisingly often want to know is, what are they going to ask me to do? Because people can be quite wary about what research actually involves. And so it's important to have some sort of idea for them. Research in the UK and is, and certainly from the NHS, is covered by ethics, as you all know. And as part of that, people do get a really detailed participant information sheet and sometimes a separate carer information sheet if the carers are also going to be taking part. So that will detail the specific activities for that piece of research. But just to give people an overview of typical things they might be asked to do, a lot of research involves what are called observational studies. And so that is questionnaires, either on paper or sometimes using an iPad of some or a tablet of some sort. It might be looking at reaction times, which can be slower in people with Lewy body dementia, perhaps as part of looking at early differential diagnoses. So those sort of things are not at all invasive. Often they're done in people's homes, and people are often quite keen to get involved with those. Sometimes it might be a piece of qualitative research where people are asked about their experiences of diagnosis or of progression or something like that. Other studies often do involve blood samples. People will be told as part of the participant information how much blood is wanted. Often it's a very small amount. And they'll also be told where it's going to be used, how it's going to be used, how it's going to be stored and things. Often blood is taken for looking at biomarkers or for genetic studies, which are perhaps less common here than they are in the US or in Europe. But there are a number of studies which are starting to come up, which are looking at lumbar puncture for potential biomarkers. It's really a growth area because until we can get definitive diagnoses for Lewy body disease and dementia, it's difficult to be sure that you're targeting the correct population. And if you're targeting people with a mixed pathology and they don't improve, it's difficult to know how effective the actual Lewy body or medication or procedure targeting the alpha-synuclein has been. So lumbar punctures, they might be asked for. Often those are an optional add-on to studies because it's realised that people are sometimes not keen on those. Clinical trials, so that's involving a medication, either a new medication which might have been gone through animal studies but is undergoing first-in-man studies, or it might be a drug that they're trying to look at the dose to get the dose sorted out for and the optimum dose. So maybe a placebo element, so the patient and the staff don't know which one they're getting until they're unblinded at the end. And a lot of those trials, if the study is found to be beneficial, then even people who've been on the placebo may be offered the actual active drug at the end. There are skin biopsy studies looking at the presence of alpha-synuclein in skin, and often people will have scans as part of the protocol of the trial, either MRI or DAT scans, so dopamine transporter scans, which are often used to assist in the diagnosis of Parkinson's and of Lewy body dementia. And then particularly if it's a hallucination study, people may be asked to have an EEG as part of that. Next slide, please. So just a very whistle-stop brief few words on some trials and studies that are happening at the moment. Just if you want to give any examples to patients or to families of things that are going on. So the COBALT study is currently recruiting in the UK, and that is a study which is looking at adding in memantine for people who are already on a cholinesterase inhibitor, so people who are already on something like donepezil. This is something that's got a good evidence base in Alzheimer's and is anecdotally beneficial for some people with Lewy body dementia and Parkinson's dementia, but we don't have the randomized controlled trial evidence yet. So that's the COBALT study. There's the SIND study, which is in the US and trying to look at early stage diagnosis to differentiate Alzheimer's and Lewy body dementia based on skin samples. There's the well, okay, you can see what that is and you can practice trying to say what that is. I've had a few practices. The idea of this study, which is underway in America and is coming to UK sites as well, is to try and dissolve the alpha-synuclein in the same way as the lecanemab, which has just been approved for Alzheimer's. So I think some of our Lewy body dementia patients have been slightly disappointed to find that they would not be eligible for the lecanemab study and drug. But as we know, that's targeting a different protein, targeting amyloid, and would not be effective for them. So this is really the first disease-modifying drug for people with Lewy body dementia. So we've got quite a few symptom-controlling drugs, but this is potentially a bit of a game changer for people. So quite encouraging, I think. And then we have the PACE study, which again is in America, and that is looking at whether end-of-life prediction could be better, and we could look at the progress of DLB through demographics and increased carer burden and things like that to try and give people a better idea of how their family members and they themselves were along the trajectory of the disease. So just a few studies that are underway currently. Now, we know that taking part in research is probably not for everybody, but there are a big number of benefits which you might like to explain to patients if they ask whether or not they should get involved. So these are some of the things that people say, some of the reasons that they give why they might say, oh yes, you know, this has been a good thing for me. Hope, you know, the the benefits of positive thinking and the benefits of hope cannot really be overstated. And when you give somebody a diagnosis of a disease with no cure, it can be obviously a very difficult thing to take in, and to give people the hope that they can do something towards a potential cure or potential treatments is very powerful. People want to give back because they hugely appreciate the support that they've had from the NHS. They want to feel they're doing something, you know, and that's a very altruistic way to think, and that's commonly what people say. For some people, knowing that somebody is monitoring them frequently is hugely reassuring. We all know that a lot of memory clinics can only currently provide a diagnose and discharge service. It can be difficult to know what to go to a GP about. So that can be quite reassuring, because when you're in a research study, obviously the researchers are often contacting you, and you usually have a contact for them if you've got concerns. If you're in the research studies for something else and disease-modifying drugs come along, you're more likely to be in the right place at the right time to put yourself forward for those. People enjoy the fact that they are speaking to people in these studies who understand Lewy body dementia, and it can be quite an isolating condition for people. So not having to explain the features and the symptoms can be really beneficial for people. They're speaking to people who get what they're talking about. Some people, and often also carers, just want the confidence that everything possible can be done. And if that's, you know, taking part in every research study that they're eligible for, they will want to do that. And for other people, it's meeting others in a similar situation. You know, although Lewy body dementia is relatively common, it's nowhere near as common as, say, Alzheimer's. And so often, you know, in a small town or a village, people may know nobody else with the same condition, and they can really benefit from that social contact. So that's important. The next slide, please. So what can you do to improve research? Well, first of all, please be enthusiastic. As I said, participant information sheets are very thorough. They detail all of the downsides of the research. You don't need to do that. If you feel that somebody might like to be involved, you know, please be enthusiastic and encourage them for all those reasons that I've just highlighted. Let them know about past successes. If they're on donepezil, somebody tested that for them, or hundreds of thousands of people tested that for them in the past. The best thing to do is to ask them to join dementia research. They can sign up online. You can also sign up over the phone. Carers can sign up because they need controls. And if people want to donate their brains or look into that, excuse me, again, that's very possible. Obviously involves quite sensitive conversations, but there are resources to do that in the bigger hospitals around the country as well. And also it's PPIE, public involvement, because the more representative we have these PPIE groups of people shaping research, the more likely we are to get representation of all sorts of people being involved in the studies, and that is really important.